Chiropractic visits and VBA stroke in the U.S. A recent publication again brings to light the controversial topic of vertebral basilar stroke and chiropractic manipulation. This newest attempt to clarify any association between manipulation and VBA stroke was conducted in the U.S. and is the largest study to date. The title is Chiropractic Care and the Risk of Vertebral Basilar Stroke, Results of a Case Control Study in U.S. Commercial and Medicare Advantage Populations, published in Chiropractic and Manual Therapies in 2015. This is an open-access online journal. From past studies, it appears that patients who eventually have a VBA stroke have presented to either an MD or DC's office with a complaint of neck pain or headache. So how common is that presentation? For neck pain, there were approximately 16.4 million visits annually in the U.S., or 1.5% of all healthcare visits to hospitals and physicians' offices. For headache, there were 11 million visits annually, over 1 million outpatient hospital visits, 3.3 million emergency department visits, and 445,000 inpatient hospitalizations. And now to the study upon which this newest 2015 study is based. It's the most lauded, well-designed study to date and was published by Cassidy et al. In 2008 in Spine, entitled Risk of Vertebral Basilar Stroke and Chiropractic Care, Results of a Population-Based Case Control and Crossover Study. In this Canadian study of 100 million person years over 9 years, there were only 818 VB strokes who were hospitalized. The source population was the entire population of Ontario. The study was based on the matching of hospital records indicating VB stroke with the same patient's record of a visit to a chiropractor and or a primary care medical practitioner. The take-home points were that in those less than 45 years old, individuals were 3 times more likely to see a chiropractor or a primary care practitioner before their stroke compared to controls. There was no increased association between VB stroke and chiropractic visits in those over the age of 45. There was an association between VB stroke and patients of all ages visiting a PCP prior to stroke. Remember that cause was not studied, only the association between stroke, time, and a visit to either a chiropractor or medical doctor. Now to our current study. The purpose was to replicate the case control epidemiological design published by Cassidy et al., study the association between chiropractic care and VBA stroke, and compare the association between recent PCP care and VBA stroke in samples of the U.S. commercial and Medicare Advantage populations. The researchers also wanted to determine the value of utilizing chiropractic visits as a proxy measure for exposure to spinal manipulation, meaning in the Cassidy et al. Study there was an assumption that manipulation occurred at each chiropractic office visit. Well, is that true? This study was conducted between January 1, 2011 and December 31, 2013. As mentioned, the patient population studied and sampled was from the membership in a commercial or Medicare Advantage health plan. Members had to be either residing or working in a region where health care coverage was offered and must have Medicare Part A and Part B to join the Medicare Advantage plan. 49 states were represented. The only state not represented was North Dakota. The average annual membership was 14.7 million for the commercial group and 1.4 million for the Medicare Advantage group over the 3-year study period, which is approximately 5% of the total U.S. population. There were over 35 million unique commercial members and just over 3 million unique Medicare Advantage members. This is then the largest case control study to investigate the association between chiropractic manipulation and VBA stroke with a total of 1,829 VBA stroke cases. Let's keep that number in mind for a later comparison. Stroke was identified by records indicating the patients admitted to an acute care hospital with vertebral basilar strokes, occlusive and stenotic as defined by ICD-9 codes. The designated hazard period in this study was 0 to 30 days prior to the stroke event, with analysis at day 1, 7, 14, and 30. In other words, hazard period means the time period after an office visit from that office visit up to 30 days. Similar to other studies, the prevalence of VBA stroke was very low. In the commercial population, it was 0.021%, and in the Medicare Advantage population, it was 0.0032%. Let's look at the stats for the most recent DC visit between the stroke and control groups in the commercial population. As you can see, these are cumulative. Of the total number of VBA stroke cases, there was a total of only 1.6% of cases over the 30-day hazard period. And as a comparison, the same stats for the most recent PCP visit in the commercial population. Of the total number of VBA stroke cases, a total of almost 19% occurred over the 30-day hazard period. Now, let's look at the stats for the most recent DC visit between the stroke and control groups in the Medicare population. There was a total of only 0.3% over the 30-day period. Whereas for the most recent PCP visit in the Medicare population, there was a total of 21.3% over the 30-day period. Cases in both the commercial and Medicare Advantage populations were more likely to have at least one comorbid condition. However, only hypertension had a positive association with cervical artery dissection. So let's summarize. The data indicates that there is no association between chiropractic visits and VBA stroke regardless of age stratification in either the commercial or Medicare Advantage populations. There was a significant association between PCP visits and VBA stroke regardless of the length of the hazard period. As usual, all studies have limitations. In this study, the limitations were ironic given they were due to the rarity of reporting VBA stroke. The researchers were not able to compute estimates specifically for headache and neck pain diagnoses due to small numbers, and there was insufficient data to calculate estimates and confidence intervals for 7 measures for chiropractic visits. And some additional limitations were that we don't know which regions were manipulated on each visit. We don't know what type of manipulation was used at each visit, or whether manipulation was even utilized, or frankly, what actually occurred at each visit. But what we do know is that spinal manipulative therapy was not reported by chiropractors in more than 30% of commercial cases. So less than 70% of stroke cases associated with chiropractic care included spinal manipulative therapy. Stated another way, in the commercial population, 20.5% of all VBA stroke cases were associated with either a DC or PCP visit. However, with DC visits, it was only 1.6%, but for PCP visits, it was 18.9%. So the obvious question should be, what about the remaining 79.5% of cases? And in the Medicare population, 21.6% of all VBA stroke cases were associated with either a DC or PCP visit. However, with DC visits, it was only 0.3%, but for PCP visits, it was 21.3%. And so again, what about the other 78.4% of cases? Specifically, what are the risk associations for VBA stroke for these other individuals given case control studies can't identify cause? Knowing that the rates of VBA stroke are equal or greater for patients seeing an MD, and that MDs don't traditionally perform manipulation, a manipulation-based mechanical association is unlikely. What then is common among patients who see either an MD or DC and the vast majority who do not? And if cause cannot be identified, isn't it more productive to approach VBA stroke by trying to find preventive measures or more sensitive diagnostic clues? It would seem these would be the most important research questions worth pursuing. In the Medicare population, only 3 strokes occurred in the 30-day period, and none in the first 7 days. So although cause and effect cannot be determined in this type of study design, logically, it would seem that if manipulation did cause stroke in this population, why did it not occur sooner? Taken together with prior evidence, this study seems to suggest the following talking points with patients and other healthcare practitioners. VBA stroke is extremely rare. When it does occur, it's unrelated to a DC or MD visit about 80% of the time, meaning 80% of the time it is due to some unknown cause and is likely then spontaneous, likely dissection. Therefore, it is unassociated with manipulation. This is further supported by the fact manipulation was reported in only 70% of chiropractic visits, and there were no VBA strokes in the Medicare population of this study in the first 7 days. There is no test to rule in or rule out the possibility of VBA stroke, given it is likely dissection in most cases. The most sensitive but not specific presentation is a new non-traumatic onset of headache or neck pain, most likely in the temporal regions and lateral neck based on referral zone studies. So in essence, VBA stroke is most likely a spontaneous event that will occur at some point in time in select individuals, and the situation or context in which it occurs coincidentally implies cause when no such relationship exists. We will probably never know due to its rarity whether in any specific case manipulation is the cause, but what we can feel certain about is that most of the time it is not, and if it is associated, it is the patient being in the wrong place at the wrong time from the perspective of the healthcare practitioner.